Today's episode is brought to you by the Nuance Dragon Ambient Experience, or DAX for short. This is AI-powered ambient technology that helps physicians be more efficient and reduce clinical documentation burden. We have a lot of that, Kristen.
Sure do.
To learn more about how the DAX Copilot can help reduce burnout and restore the joy of practicing medicine, we got to restore that joy. Stick around after the episode or visit nuance.com/discover-DAX. That's nuance.com/discover-DAX. Knock, knock. Hi. Hey, everybody. Welcome to Knock, Knock. With me, Dr. Glaucoma, your host, your one-stop shop for all things eyeballs. I'm so glad you're here. We got a lot to talk about. I'm recording this very late. It's almost midnight, and this is my little recording time. I am tired, but I wanted to get this done. I wanted to talk. I wanted to just decompress a bit with a little eyeball knowledge. I know it doesn't make any sense to hear me say that out loud, but it does. I enjoy it. I only do this. I do have to work tomorrow. That's the only downside. Like, I feel okay now. I feel it a little bit. I could fall asleep right now. I'm going to really feel it tomorrow. That's why I only do this before clinic days, not when I'm operating. All right. Those are the OR mornings. I've got to be on my game. I got to be ready because I do like 12, 14 cases sometimes in a morning, cataract surgery. So it's fast paced. It's going. And I know I'm going to have to be heavily caffeinated tomorrow. All right. I can't do that when I'm operating, you guys, because I operate under a microscope. I'm doing microsurgery. I don't want to be shaking. I don't want to be trembling. Don't need that. Don't need that under a microscope. All right. So, I could do it, but it's not as fun to do that surgery like that. And the patients don't want their surgeon to be shaky. So a normal amount of caffeine, I can do just fine with surgery. But if I have to go up a little bit because I was up half the night talking to my social media audience, I'll need more. So clinic tomorrow. It's going to be a bit of a struggle. That's okay. We'll get, all the years of med school and residency where I was up all night and had to do clinic all day the next day have set me up for success. I know how to handle it. I know how to handle a little sleep deprivation. All right. That's not a problem. I can do it. But that's tomorrow Glaucomflecken's problem. All right. Not now, not tonight, Glaucomflecken. Tonight, Glaucomflecken is going to talk to you about glaucoma, the namesake, glaucoma. I did an episode about angle closure glaucoma, right toward the beginning of doing these Knock Knock Eye episodes, but I haven't done like regular glaucoma, like primary open angle glaucoma. And we're going to do it in the context of another episode of famous eyes. Famous eyeballs. Still workshopping that name. That's really all I got right now. Let me know if you have a better one. Where I take a celebrity who has a very well-known eyeball problem, and then we talk about it. What is that problem? What problems does it cause? What are the treatments? What's their vision like? All that stuff. And so I'll tell you who the celebrities are today in a second. But before we get to the world of glaucoma, which, God, it's riveting. Let's go through some comments. So about I think 2 episodes ago, I did an episode of eye myths debunked. So I took all like all those myths that you hear growing up about like how you need to eat carrots to protect your vision, don't sit too close to the TV, babies' eyeballs don't grow as they get older. It still cracks me up every time I think of like babies with adult-sized eyeballs. I addressed all these in an episode, and it was great. I got a lot of good feedback on it, a lot of great comments. So I thought I could I could read some of these. Um, at 8 kinds of blue. So before watching, I believed the fully formed baby eyes and carrot propaganda. And now I know for sure glasses aren't like drugs. You don't get a tolerance. Thanks, dude. Yeah, right. No, baby eyes, they do grow. Baby eyes grow from about 17 millimeters when they're born to like 22 to 24 millimeters as a fully grown adult. And you can get vitamin A from anything. It doesn't have to be carrots, you guys. A couple really interesting comments. So at CCRLH85, the TV one was based on a nugget of truth. I didn't know this. I was ready. This is why I love reading the YouTube comments, because people come in with all kinds of information. A small number of old CRTs decades ago, I'm not sure what CRT means, had bad filters and actually blasted the area right in front of the TV with X-rays. So they were recalled, but the don't sit too close to the TV thing stuck. That's fantastic. I love that. It sounds true. I'm actually going to look it up. I haven't had time yet, but I love that's such a cool piece of trivia that the like earliest like cathode ray tube, maybe that's what it is. The earliest form of TVs blasted everybody with X-rays. Here's another fun one. I met one woman this is from at Sakamus Prime. I met one woman who was colorblind. She mentioned that she'd always thought Yoda was just kind of brown, right up until a scene in Revenge of the Sith where the Emperor says, "My little green friend." It's just like, what? She then had to ask her friends if Yoda was actually green. Isn't that interesting that like people who are colorblind, they live a normal life. They can't fly fighter planes, but they live a normal life. And a lot of times don't even know they're colorblind until something like that happens where they think Yoda's brown. That's so fascinating to me. Let's see. And what else? What else we got? I talked about the giant eyelashes that are popular now. People had comments about that. A lot of people were agreeing. Some people are really adamant against those things. People telling me don't call it X. I still have trouble calling Twitter X. I just can't do it. Is it really? Oh, this is a good one. At Mike Kushka 998. Is it really illegal to turn the light on in the car at night? I have never heard that it's illegal. I feel like this is a generational thing where at least I was always told anytime I was like in the back of the seat of the car with the light on because I wanted to read something, I was always like told by my parents, like, turn off the light. I can't see anything. And I think that was maybe a bit overblown, or it could just be that my parents were developing cataracts. I don't know. But that kind of light in your rear view mirror does generate a lot of glare. So it does wash out your ability to see behind the car because you have light coming at you you're not going to be able to see. And so it's certainly not illegal. Like, I've never heard that, but it does affect the driver by causing glare. I don't know if that's a thing. I feel like most of the time, like, people are like on screens now in the car, and which has its own light, and so you don't need a light on in the car. But my oldest daughter is a crazy avid reader, and one time she drained my car battery because she forgot to turn it off, which is a thing that I'm pretty sure I did when I was a kid too. So, anyway, at Tom, this is an interesting question. At Tom Kadonu 3. Hey, I have a question for you. I work in radiology and spend most of my time in fluoroscopy, which is a high radiation area. Do you have thoughts on lead glasses to prevent cataracts? Yeah, I've got thoughts. Like, that would work, but you couldn't see anything. I've always thought about that, though. Like, everybody, you wear something to protect your testicles in your ovaries. So you wear something around your pelvis. You wear like the apron. You wear something around your thyroid. But nothing, nothing for your eyes. I don't know what the latest technology is. Is there something? That can't be lead. You can't see anything. So I don't know if there's like some kind of eye protection, because obviously you can get it. Maybe it's not as much of a high turnover area as your gonads and your thyroid, but it can cause. I mean, cataracts can be taken out, but anyway, I think it'd be a good idea. Someone could invent a way to do it without being blind by lead. So anyway, it's great. I love those comments. Thank you all for watching on YouTube and those of you who watch elsewhere or listen elsewhere. I guess you can't watch anywhere else. It's gonna have to be here. All right, so that is the eye myths debunked, and there were some myths that I didn't even get to. So that was a good one with the light in the car. I didn't think about that. Okay. So let's see where we're at. Let's take a break. Yeah, let's take a break, and we'll come back with our famous eyes. Okay, here we go. Here we go. Last week was Forrest Whitaker with his ptosis. This week we have Bono. That's right, Bono from U2. We've all seen him. He wears the glasses. They're like kind of sport glasses that have a tint to them. Usually it's kind of like a yellow tint. I've seen him in different tints, but most of the time when patients like having glasses like this, who have glaucoma, that's the disease that we're talking about, they do appreciate a tint to their glasses, because when you have glaucoma, one thing that's associated with that is lots of problems with glare and halos. Really, anytime you have damage to the optic nerve, you visual aberrations. You can have issues like this, and so tinted glasses can really help. Now it's just I don't know how much he needs it. He has said in interviews that it does help. It helps cut down on those things, but now it's like his look, right? Like that's Bono. They look great too. I love getting patients those because they do look good, and they can really be helpful, especially with driving. Anything we need like the best acuity you possibly can on the road. So anyway, we're talking about eyeballs, and lots of famous people have had glaucoma. So Ray Charles is another one. You guys maybe didn't know. Ray Charles was blind from juvenile glaucoma when he was about 4 years old, which probably would be considered congenital glaucoma, because to have congenital glaucoma, it has to show up before you're 2. And I think he was blind by age 4. So I probably started at birth and then just progressed and was not picked up, which is a separate topic. Congenital glaucoma is something that we can talk about. But today it's more primary open angle glaucoma. Your run of the mill glaucoma, your the glaucoma that a lot of people get later in life. We've talked about angle closure glaucoma, but we haven't talked about primary open angle glaucoma. So just to give you just a 1 minute, maybe more, summary of what is glaucoma. Let's answer that. How about that? So glaucoma is a disease where a particular pressure inside your eye causes damage to the optic nerve, resulting in visual field loss. Most commonly, it's your peripheral vision, but there are certain types of glaucoma that can preferentially take out the center of your vision. That's not as common. Most of the glaucoma people understand as the thing that takes out your peripheral vision, which is what makes it a tricky disease, because people can have it and not know they have it. until they have lost a significant amount of their peripheral vision. And they start noticing, oh, wait, I'm not seeing cars come up, fast enough. And then they come in, we get checked out. Sure enough, they have a lot of damage to their optic nerve from high pressure. So big picture, though, glaucoma is a huge public health problem throughout the world. So it is the second leading cause of blindness worldwide after cataracts. But cataracts are a cause of reversible blindness. So it is the leading cause of irreversible blindness. It's so there's a huge amount of advocacy work that's done just around awareness and getting people in to have regular checkups. The biggest risk factors for developing glaucoma are age. So your risk of, we're talking about primary open-angle glaucoma, the most common type of glaucoma. The prevalence increases as you get older. Eye pressure is the biggest risk factor. So normal eye pressure is, and we have studies that have established this, it's 11 to 21, basically. That's what we consider normal, quote unquote, normal eye pressure. If you have an eye pressure in that range, very unlikely that you are going to have any problems related to eye pressure. And so when we see people who have ocular hypertension, their eye pressure gets higher. It gets in the 25, 30, sometimes 35 range. That's when we start to see people start getting damage. So eye pressure is a risk factor. People who are nearsighted have a little bit higher risk of developing glaucoma later in life. Family history is also a pretty big risk factor. So first degree relative specifically. So if you have a sibling, a parent, your odds go up that you're going to develop glaucoma. And corneal thickness. I'm not going to spend too much time on that, but if you have a thinner cornea, you're at higher risk for glaucoma than a thicker cornea. So you can impress your eye doctor when you go and say, "Hey, how thick is my cornea?" You want those nice, thick, juicy corneas. You need 600 microns. Oh, be still, my heart. I love myself a good 600 micron cornea. Under 500, we're not ideal. Still wonderful corneas, not ideal. 600, you're golden. You're good. That's amazing. We love that. All right, so those are the risk factors. And so what exactly is happening with glaucoma? Why is the pressure high? Well, if you recall, it was like 5 months ago, so you probably don't recall. If you do recall, maybe you should be a physician because you've got incredible memory. When we talked about angle closure glaucoma, the reason that happens is for whatever reason, there's a lot of different reasons, the drainage system inside the eye will close. We'll get shut down. We'll get obstructed. Lots of reasons. And the eye pressure will start to build up in the eye because the eye is constantly making fluid from the ciliary body that's inside the eye. It makes aqueous fluid. It's constantly making fluid. And then the trabecular meshwork, which is where the cornea on the front of the eye attaches or meets the iris, right there in the angle. We call the angle of the eye. That's where your trabecular meshwork, that's where your outflow channel is. Your eye is constantly making fluid from the ciliary body and draining fluid through the trabecular meshwork, through the angle. And so with angle closure glaucoma, you get obstruction of that angle that causes the eye pressure, just like oil in a bath, just oil in a bath. What am I talking about? Just like water in a bathtub. You plug the drain, it's going to fill up, the pressure's going to go high, you're going to very quickly lose vision. But that's not what we're talking about today. We're talking about Bono and his, actually, here I am assuming primary open-angle glaucoma, where there is just maybe an imbalance. Maybe there's a little bit too much aqueous being made. Maybe there's a little bit of outflow obstruction. Here's the thing. There are lots of proposed mechanisms for glaucoma, lots of proposed etiologies. But we're not totally sure. We have theories. We have theories about trabecular endothelial cell loss, where you have these trabecular beams that fuse. We have this possible loss of phagocytic activity in the angle that causes things to get plugged up. We have problems in Schlemm's canal, reduced pore size and density in the wall of Schlemm's canal. There's also this excitotoxic damage from excessive glutamate, autoimmune-mediated nerve damage, loss of neurotrophic factors that keep the angle and everything in the eye healthy, failure of cellular repair mechanisms. The point is, we don't really know. And that's what makes glaucoma so challenging, is because the underlying reasons, sometimes we know, like someone has angle closure glaucoma, we can figure out what is plugging that drain and what we need to do to try to get it open again. Yes, there are some forms of glaucoma where we do know exactly what's causing it and we can potentially cure it. But the vast majority of glaucoma, some other mechanisms, probably multiple mechanisms at play, we don't know. So what do? Well, if we can't curatively treat this disease because we don't really know the underlying pathophysiologic factors, or maybe we do know, but right now there's no way to fix it, well, we treat it. We manage it. If we can't cure it, we're going to manage the hell out of it. And boy, do we know how to manage a good glaucoma. Oh man, let's get to it, shall we? Let's talk about all the ways that we manage glaucoma. And so when I say manage, I mentioned those risk factors. And so you look at those risk factors, and be like, okay, these are all things that might be contributing to someone being diagnosed with glaucoma. Which of these can we impact? Which of these can we change, modify? Age? No. Refractive error? No. Corneal thickness? No. Family history? No. I didn't mention race, so African Americans are more affected. Can't affect that. Can't change that. And so the only thing that we're left with is eye pressure. And so that is how you treat glaucoma. Glaucoma, the treatment is all aimed at lowering the eye pressure. So in a way, glaucoma is actually the simplest possible subspecialty in ophthalmology. Maybe one of the simplest subspecialties in all of medicine, because you're doing one thing. You're trying to lower the eye pressure, but within that thing, it is incredibly complicated with so many different possible treatments and ways to approach the ultimate goal of lowering the eye pressure. But it really is beautiful in that way. That's really all you're trying to do. Like you could devote your whole career to glaucoma. We have glaucoma specialists. That's all they do is glaucoma, and all they do all day is things to lower eye pressure. It's kind of cool in its simplicity. But then when you really get into it, oh man, there's so much there. There's a reason it is its own career. Like as a comprehensive ophthalmologist, I do the surface level stuff. All right. I can start eye drops. I can do a little bit of laser stuff. I can do a little bit of surgery stuff. But when you get into it, when you have refractory cases of glaucoma where that eye pressure is not coming down, that patient's on as many eye drops as you can give them, and it's not low enough. The patient is still losing vision, damage to the optic nerve. Glaucoma specialists have more things they can do. So the first line, well, depending on who you ask, there's a couple of first line treatments you could do. So we'll talk about eye drops first. So eye drops, tried and true, they've been around forever. Timolol, carbonic anhydrase inhibitors, prostaglandin analogs. There's old school things like pilocarpine we don't really use anymore, just in special circumstances. But most of these eye drops are aimed at reducing the flow of aqueous. So you can kind of slow down that aqueous production. Because again, to lower the eye pressure, what do you got to do? Well, you either got to increase the outflow, you got to open the drain, or you got to turn off the faucet. One of those two things to change the equilibrium, to get that pressure lower. So most of the eye drops are aimed at turning off the faucet. Some of them are like the prostaglandins, they increase outflow, so kind of open up the drain a little bit. And I'd say eye drops are a really good first line because a lot of them are like once a day, some are twice a day. Once you get, into, 2 or 3 different drops, well, that becomes more challenging because patients are on 5, 6, 7, 8 drops a day that they're having to remember to put in. And again, most of our patients are a little bit older, right? And so it gets to be very challenging with all their other medications that they have to take and all their doctor's appointments. And you can see how it can be very difficult to maintain that kind of regimen. So in lieu of adding another eye drop to maybe an already very busy medication regimen overall for a patient, we have lasers we could do. So what does a laser do? So we have our main type of laser is called selective trabeculoplasty. So it's SLT, selective laser trabeculoplasty. Trabeculoplasty, that's it. So I just call it SLT. I haven't looked at the acronym in a while. And so what this does, it's a laser. You do it, one time, and you basically what it does is it opens up the outflow channel a little bit. So it gives you a little bit more opening there, opens up that drain a little bit, but it can also potentially save a patient from being on a drop. So you can get a more lasting IOP, intraocular pressure lowering effect that doesn't require daily medication. So that's another potential treatment option. And what's really blown up though in the past, so we got eye drops and lasers. We've had these things for decades. Eye drops and lasers. We're still coming up with new eye drops. It's amazing. Still finding ways to lower eye pressure through eye drops. But what's really exploded in the world of glaucoma over the past decade are the surgical options. So back in the day, even like back whenever I first started residency, God, it hasn't even been, it's crazy how quickly this has gone. When I first started residency, there were only like a couple primary ways of lowering eye pressure. One was called what we call them trabs and tubes. So trabeculectomy. Trabeculectomy is it's this barbaric surgery that still has use today because it's been around forever. Since the dawn of glaucoma, this surgery has been around, where you basically create a new outflow tract from the eye. So you go on the sclera and you actually, using a blade, you cut a window into that white part of the eye, like a little flap that allows fluid to egress from the eye, bypassing the traditional trabecular meshwork, the angle. You bypass the angle completely. Now fluid has a different place to come out. And that is like throwing a nuclear bomb on the IOP. That will lower the pressure to levels of like 2, 3, 4. So patients with very severe glaucoma, where you're trying to save the last few little neurons in that optic nerve, you might do a trabeculectomy. This is like, again, big time. It's probably the most invasive surgery we have in glaucoma. Then there are other ways of bypassing the outflow tract. We have tubes. They kind of do a similar thing instead, but it's a little bit more controlled. And instead of making a flap, you're putting a device that inserts a tube into the eye, and then the fluid can come outside of the eye. Also a good option. They have their pros and cons. That's a little bit outside the scope of Knock Knock Eye today. But then I mentioned all the advances in the past 10 years, and this has been through the rise of minimally invasive glaucoma surgery. So now we have these things called they're trabecular stents, or devices that you can kind of plug directly into the angle of the eye that act as a way of allowing the fluid to get out of the trabecular meshwork more efficiently. You can actually cut into the angle. These are like basically going inside the eye, and you're removing that angle, or you're opening the angle in some way. Basically, instead of going outside the eye, you're doing all of this inside the eye. So it's more technical, more difficult surgery. But now our techniques are so good that most ophthalmologists can do some of these things. I don't do a lot of them because I have like 2 or 3 glaucoma specialists I can refer to who do so many more than me. But I have been trained in some of these, and so I have the ability to do it if I so choose. And there really are cool surgeries and can prevent some of the more invasive surgeries that have been done for decades. Now we have these minimally invasive surgeries. And glaucoma, more so than I think anything else in ophthalmology, is really an art. When do you decide to do these surgeries? Which surgery do you decide to do? There's probably a dozen different minimally invasive surgeries you can do for glaucoma. Which one do you choose? Why do you choose it? What stage of glaucoma do you do that surgery? What does the data show? How do drops factor into this? Do you stop drops? Do you keep them going? How many times can you do a laser on top of this? Can you combine multiple of these minimally invasive surgeries? Or when are those not even going to be useful and you need to go to something bigger like a tube or a trap? It's very complex. But it's the crazy thing is that it all comes down to just getting that eye pressure lower, and we have 1,000 different ways to do it. So that's Bono and his glaucoma. That's what we do with glaucoma. And the reason I did not choose glaucoma, and I still wouldn't choose it if I could go back, even though it is the hottest thing in ophthalmology, is just because I didn't have the patience. I can't do one thing like that. Like, I feel like ophthalmology is already subspecialized enough. Like, I want to have a little bit more of a variety, and so glaucoma just wasn't for me. And God, I'll be honest, you guys, and I hope my mentors back in Iowa aren't listening to this. I was bored to tears. I found it very boring. I had wonderful educators, wonderful mentors and surgeons and attendings that taught me surgery, and they did an incredible job because I'm a good surgeon. But man, was it boring. Oh. But you know what? Every ophthalmologist, if you practice long enough, you end up with a glaucoma clinic because glaucoma is a lifelong disease. All these things we're talking about, all right? They are ways of mitigating the risk of having glaucoma and losing vision from glaucoma. But again, we don't really know how to cure glaucoma. We just keep it from getting worse. So, and we're really good at it. Shout out to all the glaucoma specialists, all my colleagues out there. All right. There you have it. Primary open-angle glaucoma. I think the only remaining glaucoma topic we'll probably cover is congenital glaucoma, because there's there's some interesting stuff there that we could discuss. But give me your questions. Give me your comments. Again, I'm going to see them on YouTube at Glaucomfleckens. Go and subscribe. I would appreciate a subscription. We just launched the channel. We're trying to build it up. And I will be monitoring the comments over there. So let me know if you have any thoughts. If you want to tell me your stories about glaucoma and what you think of the disease, or if you have any follow-up questions, anything I didn't cover, I'd be happy to address it in a later episode whenever I go through the comments. So you can email me, knock-knock-hi at human-content.com. You can also, reach out on YouTube and give me your content ideas. What do you have a celebrity, a famous person that you know has an eye problem that you want me to talk about? Happy to. I've got a list. All right, I'm not going to reveal my list. I'm going to leave it a surprise. But today it was Bono. We'll throw Ray Charles in there, although Ray Charles again was probably congenital glaucoma, but Bono with his glare reducing glasses. So thank you, Bono, for talking about it. It's hard to talk about eye problems or just any medical problems, but he's talked about in interviews, and I think that kind of thing does a lot to raise awareness for some of these diseases, especially something like glaucoma, which can be insidious. You don't know you have it because most of the time the first sign of damage is peripheral vision loss. That's not easy for someone to pick up on their own unless they go to an eye doctor. And if you come in, you're like, hey, I got a strong family history of glaucoma. My mom had glaucoma. Well, we'll do a visual field test, or we'll do a map of your optic nerve. We'll check your eye pressure. We'll check your corneal thickness. We'll assess for all your possible risk factors. We'll be able to tell you if you have glaucoma or if you're at risk for glaucoma. And but it does take going to the eye doctor. I say everybody over the age of 70 should be having a yearly eye exam, because lots of things happen in your 70s. Cataracts, glaucoma, macular degeneration all become very common. You should also be seen probably like every 2 years or so after the age of 60, so we can catch these things early. So yeah, that's most of my patient population, and I love them. So thank you all for listening. I'm your host, Will Flannery, also known as Dr. Glaucomflecken. Thanks to my executive producers, Aaron Corney, Rob Goldman, and Shanti Brook. Editor and engineers, Jason Portizo. Our music is by Omer Binsvi. Knock Knock Hi is a human content production. We'll see you next time, everyone.
Knock, knock, goodbye.
Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen, or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts. Or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Hope you subscribe, leave a comment below. Let us know what you think.